Is Dr. Professor Shweta Mittal Gupta. She is Secretary General Indian Fertility Society and has been treasurer and convener for SIG Reproductive and Endocrinology IFS from 22 to 24. And she has been recipient of various awards like Vigyan Vardhan Award, Dronacharya Award, etc. And she's the first fellow National Board Reproductive Medicine, credited for first pregnancy from frozen thawed oocyte in North India. Welcome you, ma'am.
Thank you so much.
And
Thank you for such warm welcome. Great opportunity for me to learn some perinatology, fetal medicine. And thank you, Dr. Neeru, my dear colleague, organizers of Gurgaon Obs-Gynae Society and the Haryana chapter of ISPAT for calling me. Slightly diverging the topic, we heard really beautiful lecture about what epigenetics can do, what havoc it can do to our body. And now we will just see that can there be some reparative mechanism. Though I would say if my patients come, I always tell them there's nothing more than lifestyle what can really change. What we cannot change, I think, are genes, but what we can slightly alter is maybe the epigenetic change or certain induced changes which are happening either by our natural mechanisms or by pharmaceutical interventions. So the question is that where have all the conceptions gone? This was said by Robert and Loy, and they said as much as 80% of the embryos could be lost because we only see the tip of the iceberg when we are looking at clinical pregnancy losses. And very highly cited reviews could say that in conclusion, you could see that maybe 60 to 70% of these pregnancies are getting lost. We are not even detecting them. So just very quickly running through it, that what is the basic mechanism is chromosomal aneuploidies. And that is why the real question arises even in our IVF practice, that does recurrent implantation failure even exist? Is it a real terminology or is it just chromosomal aneuploidies what we are dealing with mostly? So Nobel Prize winner in 2009 from Physiology and Medicine, they said that how chromosomes are protected by telomeres, and this is how the longevity of the life is being, targeted at, that possibly the Japanese people or that segment of Japan where the longevity is very long, maybe they have very long telomeres and which is helping them in, living for longer period of time. And the enzyme telomerase. So what telomere does, if you can see in the picture, that the ends of the chromosome are our telomeres, and what it does is that it is like a protective cap on the chromosome and which prevents deterioration of chromosome. And telomerase is an enzyme that adds DNA to the telomeres, mainly active in reproductive cells, maintaining their length. So telomeres can shorten with each cell division, leading to cellular senescence. That means they get progeric. And when critically short, which is around 5,000 bases, it results in cell aging and death. So then what could be happening? Now this shortening of telomere length leads to decrease in oocyte and embryo quality, could be happening in recurrent unexplained miscarriages, decreased pregnancy rates, growth restriction, and even in causing more aneuploidies, which could happen with increasing maternal age, even with increasing paternal age. The oocyte telomere lengths are affected by several factors. They could be advanced maternal age, you're smoking, more anything like any infections causing more reactive oxygen species, obesity, diabetes, and repeated stimulation cycles also could be like giving very high dose of gonadotropins. And that is why the world says that there is an upper ceiling dose of drugs, and do not give the drugs beyond that. It is exactly like you have a saturation level for iron, right? The moment you give iron tablets which have very high concentration of iron, it never gets absorbed by the body. And the same way is possible even with gonadotropins. If you give very higher doses of gonadotropin, all your FSH receptors are saturated and this is going waste, and excessive stimulation is bringing more aneuploidies in the oocytes. So shorter telomeres have been observed in different diseases of the reproductive system, which could be ovarian cancers, could be endometriosis, premature ovarian failure, and polycystic ovarian syndrome. Now, shortening of telomere length further leads to decrease in mature oocytes, your antral follicle count, AMH in cumulus cells, and granulosa cells. So, these are the postulated theories what could be happening. Now, what is the impact, which I just said, that repeated ART cycles can also impact the telomerase length. So, we have to be very careful in choosing what is the higher dose we are using of drugs when we are stimulating our patients. During ART procedure, the oocyte and embryos exposed to many environmental factors and chemicals which can adversely affect telomeres and telomerase activity. Now, telomere length and telomerase activity in human oocytes in a normal cycle, and they compared that it reduces in an ART cycle. Also, maybe we are dealing with infertility, we are dealing with genetic issues. It could not always be directly only our ovarian stimulation, but there are many factors which are coming together and playing their role. So, if we sum up, age, obesity, thyroid issues, hypertension, diabetes, and your stimulation protocols, all of them can in themselves bring more reactive oxygen species, can bring more inflammation, and there are certain proteins which are present in different parts of our oocyte, and they are called sirtuins, and that can be down regulated, which I'm going to just hit in a minute. And low levels of these proteins can destabilize the telomerase, and it can activate DNA damage. This causes telomerase shortening, and this leads to cell death. So David Sinclair is very, popular because he says that this is what I am working at. I'm working at anti-aging, and I'm working at increasing the telomere length. Now, what are SIRTUINS are silent information regulator proteins. Now, they are present in the whole of ovarian follicle, on the ovarian epithelium, stroma, and in the luteinized granulosa cells. And there are different levels of these kind of proteins. They will participate in different cellular processes in female reproductive tract, including regulation of heterochromatin, telomere maintenance, and repair of DNA damage. So let's be very simple. We have understood telomeres, they are protecting our chromosomes. We know the DNA damage. We just heard in the previous lecture also that how DNA can be damaged. Now, there are three types of proteins. This is 1, 2, and 3. The SIRT1 protein can work on making ovarian reserve, follicular reserve better, more oocyte maturation. In mitochondrial abundance, we know when we even give CoQ enzyme, we are basically trying to target better mitochondria. And we also know that there are mitochondrial diseases, and there is a third party reproduction where mitochondria has been transferred to overcome mitochondrial diseases. It makes fertilization better, makes embryo development better. Then, looking at SIRT2, it will regulate the meiosis, more oocyte maturation. It will look at spindle. Now, we know that with advancing ages, the spindle becomes very fragile. Now, what about SIRT3? They make fertilization better. They look into the early embryonic development, luteinization process, mitochondrial protein hyperacylation. So, if we can make use of these proteins, we are upregulating the telomerase. I think I'm not going to repeat this because I have much more things to discuss. So coming to role of SIRT in reproductive aging, as the age increases, the SIRT downregulates, and they are major determining factor in ovarian aging and quality of gametes. Then what happens? Obesity again downregulates these proteins SIRT. Then type 2 diabetes, type 1 diabetes, hypertension again downregulates SIRT1. And in PCOS also, because many a times I hear in discussion, I did an IVF cycle for PCOS and I found the oocytes were very poor in quality. So possibly we are looking at some epigenetic changes, high androgen levels, more ROS damage in these girls, and this could be because their SIRT1 are downregulated because of the disease in itself. Now coming to second molecule, which is called nuclear factor erythroid-2. It's complicated. We can remember it as NRF2. Now it is now present in the cytoplasm. So that was present in the granulosa cells at different levels. This is present in the cytoplasm. It is in the inactive form. It has to get activated to keep one protein. Then it will go into the nucleus. It will dimerize with small proteins there, and it will activate some battery of genes. So let's just see that a molecule which is in the cytoplasm needs to get activated, needs to go into the nucleus and then have its antioxidant action. So this is the relationship that as the age increases, again we are getting deficient in NRF2. Then maternal age is associated with spindle and chromosomal abnormalities, which is suppressed by NRF2 overexpression. So NRF2 belongs to a cap and collar subfamily. We don't have to remember so much. It will translocate itself into the nucleus. It will dimerize with small proteins and activate a battery of genes. Now that will help in anti-inflammatory action by activating HO1 axis. So it basically inhibits inflammatory mediators, which are cytokines and chemokines. Now we know when we are talking of RPLs, recurrent pregnancy losses, we are talking of more of Th1 activity, more of natural killer cell activity, more of cytokines and chemokines. It is in a similar fashion. So these two, if there is reduced protein, which is SIRT and NRF2, will lead to telomerase shortening. So if you can have a molecule, so let's start with two molecules, nicotinamide mononucleotide activator. What will it do? Just see the blue boxes. It will promote endometrial health, improve the sperm function. It will cause more mature follicle, can boost your AMH, oocyte quality and DNA quality, and improve embryo quality and maybe help in reduction of miscarriage. But this is more applicable in unexplained causes or age related and the factors which I said, but not as a blanket rule for all. And what will it do? It will work on the telomere length. It can be a potential biomarker linked to NMN. Then it elongates the telomere length in humans and it reduces the fecal bacterial diversity, increases abundance in Helicobacter. So that's all right. So basically it makes our it's acting like a probiotic and enhance intestinal homeostasis, which has been currently reported in NMN treatment by regulating the gut microbiota. Now, a lot has been talked about gut microbiota, and a lot has been also discussed that does it hold so much of meaning or is it more of a theoretical benefit? Now, what happened when we gave this molecule on telomere length? It was given in 80 healthy men, 40 to 60 years, 500 milligrams per day, 90 days of therapy, and they found that there was an increase in the telomere length after 90 days of treatment. Underlying mechanism was on increasing the NMM, increasing telomere length, and associated with increased NAD levels, and NMN, that is nicotinamide, won't cause any marked deleterious effect. Now, I want to come to the study. I think I'm going to speak, otherwise my time will be up. The second molecule is L-ergothioneine, which is an NRF2 activator. So this, what it does, it will bind to MAF, which was the protein which I was talking about. It will reduce the follicular death. It will increase the mature follicles, reduce the inflammatory genes, and prevent embryo dysfunction. On the other hand, it will reduce the spindle formation defects and it will improve the oocyte quality. So basically, it is working at multiple levels. Now, it is a natural antioxidant, which is L-ergothioneine, and it can accumulate millimolar concentration in certain tissues without toxicity. It regulates the levels of peroxidases and antioxidant enzymes. It's a powerful cytoprotective role to protect DNA, proteins, lipids, and other components from oxidative damage, and it can protect the cells from oxidative damage. So this is the FERT SIRT trial, which was a multi-center. It was a randomized double-blind trial. 100 women were selected who had those risk factors, which I have just mentioned. 50 were given this molecule, which is a patented molecule from Celgenics, EQOQ, which contained nicotinamide and L-ergothioneine. Which was a standard protocol, and 50 women were not given. So they found that 82% women had normal morphology oocytes as compared to 55 who received placebo. 79% had better oocyte maturation rate with lesser chromosomal aneuploidy rate. There was better high quality embryo, more blastocyst formation, and lesser embryo fragmentation. And successful implantation rate was way higher. Well, I need to read this more closely because 92% sounds higher to me. And clinical pregnancy rate, yes, was 66% vis-a-vis 32%, and live birth rate was also higher. So what is important is live birth rate when we look at these patients. Yeah, I'm coming to the end. So basically, synergy of SIRT and NRF2 has been recommended in this molecule. And I want to thank Cellogenics for providing me this academic data. So just before I end, this is their combination, 250 milligrams of nicotinamide and zero point 0.5 milligram of L-ergothioneine. They are recommending it twice daily, and they're recommending it at least for a month before you do a IVF cycle or you want to give it. But as much as little as during stimulation, even if they get it for about 15 days, they are saying it will have some benefit. So thank you very much for patient hearing. But I would also suggest that have your own data and have your own studies. That's also important.
Thank you, Dr. Shweta, for such a nice presentation in a such